Thank you for joining tonight's OTEP Clinical Case Webinar. The topic of the night is Women's Health and Contraception for People Who Use Opioids. And we're joined by Dr. Vicki Chase, an addiction medicine specialist, and Dr. Kelly McNamara, who's an obstetrician gynecologist at the University of Newcastle. So thank you for joining us.
Thank you.
And I'd like to begin by acknowledging the traditional custodians of the country and lands on which we meet and recognize their continuing connection to land, water, and culture, and also pay my respects to any elders past or present. So these are where people are joining from tonight. We have lots of people from the metropolitan areas, but also some people from the regional areas and about 15% who are joining us from other states, which is really great to see. Lots of people who are interested in the topic tonight. And also these are the specialties of those joining. As usual, lots of general practitioners and pharmacists, which is great to see, but people from every category. So thank you for coming. I just wanted to say a little bit about the OTEP Clinical Case Webinars. So these are monthly webinars that we hold on Tuesdays at 6 p.m. If you join live, we will send you a certificate afterwards that you can use to claim any CPD points. And if you're not able to join us live, you can always rewatch the webinars online at the OTEP website. So we'll have the link to the webinar. And a little quick housekeeping before I turn it over to our speakers. So please keep yourselves on mute unless you have any questions, but we do recommend that you type the questions in the chat. We have Dr. Sharon Reed with us today who will monitor the chat, and we'll probably keep the questions till the end of the webinar. And please remember that these webinars are recorded, so don't reveal any identifying information. And please participate, ask questions, and be considerate and polite. And I'll just turn it over to you, Kelly.
As Jessica introduced, I'm Kelly McNamara, an obstetrician gynecologist, and I've got Vicki Chase, one of my colleagues here, an addiction medicine specialist. We'll be talking to you about women's health and contraception for women who use opioids. So what we're going to cover today is three sort of domains: cervical screening, pregnancy care, and contraception. And we'll present some case studies to aid the presentation today. Just changing my view, sorry. So we've got women who use opioids have a range of reproductive health needs. We know that they have higher rates of unintended pregnancies, barriers to cervical screening, lower access to contraception. They may have increased experiences of trauma and stigma and system navigation challenges for an array of reasons. It is important when we care for women in the reproductive years that we think about the trauma-informed principles, and many of you will be very familiar with this working in the space of addiction, but it's probably more important for the reproductive health of women. Many have actually experienced interpersonal violence, sexual violence, and it just really needs to be at the forefront of our minds during the care that we provide. So thinking about all of that, I'm going to start with Ainsley. So Ainsley was a 35-year-old woman who first came to me at sort of 3 months postpartum. She was then Para 2. She was being looked after by Vicki through the Substance Use and Pregnancy Service, and it just so happened that Vicki and I were working together at the time in the Violence, Abuse and Neglect Service, and that'll be important as I talk through this case a little bit. Ainsley was engaged with SUPs really only because of previous pregnancy involvement. She wasn't actually currently using any drugs, and she was fairly stable in the community, just smoking cigarettes. But she did have a background of domestic violence in a previous relationship. That child, or that pregnancy, that first pregnancy, was complicated by substance use, and that child was in out of home care. This time was different, and 3 months postpartum, she was parenting really well. Because Vicki had been talking to her about contraception, it had come up about her last cervical screen. and she couldn't remember when it was. It was noted in the antenatal records that it was in 2015, but nothing had really been done to follow that up. So Vicki was able to log on to the to Proda, where is a, I'll show you how you can do this, but to check her previous cervical screening tests, and was able to identify that she'd had a high-grade dysplasia result in 2015, which had not been followed up. So this is a timeline of the care that Ainsley got, starting back in that 2015 cervical screening test, which was done in Justice Health. There's then a big gap until October 2023, when she had her maternity booking appointment, where somebody noted this, but really didn't do anything about it or follow up, even find the results. She then had a uncomplicated birth in April of 2024, and it was July 2024 when, during her SUPS care, it was discovered that she had this high-grade dysplasia 9 years before. I saw her within a week or so through that violence, abuse and neglect service, just because we took a no wrong door approach. When I heard about this case, I said, we'll just bring her in and I'll see her. Repeated her cervical screening test, and unsurprisingly, it came back that it was still high grade. Didn't have a colposcopy in that service, so referred her quickly to our gynaecology outpatient services. And she was seen within the month and had a biopsy which returned high-grade results, but wasn't then seen for several more months to follow that up or book her procedure called a LEPS procedure, and then that wasn't done until March 2025, where she had her procedure, which is likely to be curative. She's still waiting for her 12-month follow-up, which will be due this month. But what you can see here is a 11-year period that it's really taken from first being identified as having high-grade dysplasia to hopefully cure this month if and when she gets her follow-up, and just show the multiple points along the way in which women have barriers and access to care. And so it's really important when you come across somebody that you remember there's an opportunistic at any point you can be. What can we learn from this case? Well, there's lots of reasons why women might miss out on their cervical screening test in this space. There might be fear of pelvic examinations. This might be tied in with the previous trauma they have. You can manage this with appropriate support. We had a substance use and pregnancy nurse come to the appointments, both the appointments with me and the appointments in gynaecology, and I think on the day of theatre as well. And that was able to get her through this process. We need to be aware of things like shame and stigma, and that these are barriers that can be overcome. I think this woman probably did have competing priorities at one point in her life. That first pregnancy had been very complex psychosocially, and I think things like housing and safety probably were at the top of her priorities, and remembering about that cervical screening test that needed following up probably was on the back burner. There can be lack of continuity between services, particularly from Justice Health to local health districts. I think we're hoping that the single digital patient record might help some of that, but it needs to be on the forefront of our minds. And it's just really important, whilst this cervical screening test is part of antenatal care, it's really important we don't assume other people have done things. And this is a good example of where that didn't maybe happen to the full extent. So what can AOD clinicians do? You can ask about this as part of your routine care. You can encourage self-collection if that's part of your scope of practice. You don't need to be a GP or a gynecologist to get a woman to do a self-collected cervical screening test, but you do need to know where to refer abnormal results to. We can support with reminders of transport of referrals. You can check the screening history during pregnancy in Access Proda. I'm going to show you how to do that in a minute. And you can navigate and help navigate after abnormal results. So look, some of you, depending on what your professional background is, will have access to Proda. Some of you will be eligible to sign up, but Proda is provided by Services Australia as a place where we can access information. You can get yourself registered. And then when you go in, there's a whole big range of things that you're able to actually look at. One of them is the National Cancer Screening Register, and you click in there, you put in the patient's Medicare number, their name, date of birth, and you'll be able to actually see when their last cervical screening test was. It can be really helpful. I do this. I think Vicki does this. Lots of clinic nurses here in our institution do this as well. So that is the first case, and I think we were just going to pause for a question before I hand over to Vicki. If there's any questions, otherwise we'll move on.
Sorry, have to unmute. There aren't any questions in the chat yet, but I'll keep monitoring it. But I was just wondering, you know, how, for example, how does a domestic violence situation interfere with women's access to, these services?
Yeah, look, I think unfortunately some women experience coercive control through many ways, and there are women who are unable to access healthcare, particularly reproductive healthcare, because their partners don't allow it. And I think we've seen this quite a lot, haven't we? That might be through, commonly we see it through access to contraception, but if there's suspicion, they might not be able to attend anybody or any service that seems like a women's health service. That would be the most common way, unfortunately.
Yeah. So basically just by controlling behaviors. Yeah.
Yeah. Or controlling finances, and there are free services around, but not as many as there needs to be. So that would be another way.
Well, good. Thank you.
Right, I'm just going to jump in and talk a little about pregnancy identification and pregnancy care for women who use opiates, and really looking at it from the perspective of the role that someone as working as a drug and alcohol clinician, the role that we can have around pregnancy identification and care. So this is an extremely busy slide, but I'm just going to step through the kind of key points. I think what it illustrates is the complexity of a young woman's journey through pregnancy and the early postpartum period, and the challenges that she faced. And whilst not all our patients are this complex, I think certainly many of them are, unfortunately. So let's just start talking about Renee. So she's a 28-year-old Aboriginal woman living on the Central Coast with the support of her nan, but no other family beyond that. She was a current patient of one of the clinics on the Central Coast called Culleru Clinic, so on an opiate treatment program, and had been for a long period of time. And at this time, she was on sublingual Suboxone. So I saw her for a routine appointment, a review of her treatment program, and planning for her ongoing script. Part of my kind of standard care, particularly for women of reproductive age, is to early on think about pregnancy and pregnancy intention. We did a pregnancy test at this visit because Renee was certainly having unprotected sex, not using contraception, and very unsure. She didn't feel that it would be possible for her to be pregnant, but I guess it was always a possibility, and her urine pregnancy test was in fact positive. She then proceeded after that appointment to go off and have a dating scan, which confirmed an early intrauterine pregnancy, and she was very overwhelmed, as you can imagine. In terms of her life generally, yes, she was on an opiate treatment program, but she certainly wasn't stable in terms of her substance use. She was on some lowish dose of Suboxone. She attended infrequently to the public clinic, and she had ongoing use of opiates, but also a range of other substances as well. Initially, we attempted to stabilise her on the sublingual Suboxone, encouraging her to attend more regularly. She was not willing or able to do that, given the complexities of her life. And so we had a conversation fairly early on and transferred her to a weekly buprenorphine injection at that point in time. She was fairly unsure about what to do with regards to her pregnancy, but as the months progressed, she decided to continue with the pregnancy. As you can see, there were a range of physical, psychological, and other complexities going on for Renee. Life was very challenging, and as a result, a whole range of different services were involved in her care in the community. Those services were had to be delivered in a very flexible way, and there was a lot of assertive work done by a whole range of different clinicians, really coordinated by one of the SUPS team, and I'll talk a little bit more in the next slide about SUPS services. In the community, we stabilised Renee as best we could. She was involved with community corrections and DCJ, and there was a general consensus that some time in residential care was going to be important for her to stabilise and to be able to care for her baby. That presented a challenge where I live on the Central Coast, where she was living, because the rehabs that we have locally don't, at this point in time, accept patients on long-acting injectable buprenorphine. So it meant she did need to transfer to a rehab in Sydney. She came into hospital for a few days prior because she was smoking some cannabis. So she was here in an acute hospital bed because our inpatient unit doesn't accept patients beyond 20 weeks gestation, and then subsequently went to rehab. Unfortunately, on the day of arrival, she went into labour and she did proceed to have a cesarean section, but we returned eventually to the clinic with her, to the rehab with her infant son. And whilst it was a really challenging experience, and she reflects on those challenges, she did successfully complete the residential rehab, and has subsequently returned to live on the Central Coast, re-engaged with a whole range of services, and I'm pleased to say is very much flourishing as a mum and really doing very well considering the journey that she's been on. So I mentioned SUPS, so Substance Use in Pregnancy and Parenting Services. So I didn't realise that there were people beyond New South Wales. But certainly throughout New South Wales, I think most LHDs will have a SUPS service. They're not all the same. So the models of care and the combination of staff that work in each SUPS service vary from area to area. So what I speak to now is the service that I am part of here on the Central Coast. So we are a multidisciplinary team, a small team that all work part-time, but we have specialist drug and alcohol nursing staff, a midwife, some medical support, and more recently we've added we have a part-time social worker and a child and family health nurse. And I guess the role of the SUPS team, and I think the work that we do to achieve great outcomes is to be that kind of pivotal sort of service, really focused on care coordination, working with all of the different health services and community services that may be involved with our patients throughout pregnancy and in the postnatal period. So I just wanted to Sorry, we've just got a screen problem.
Screen's not working that well. Is everyone able to see it?
We can see that you're on the guidelines page right now.
Yep, lovely.
And can you see the whole guidelines page?
Yes.
I think we've just got an overlay of, there we go.
Okay, that might be better. Apologies.
Sorry about that. So at this point, I just wanted to do, a whirlwind discussion around opiate dependence treatment in pregnancy and the postnatal period. So, I imagine that, a full discussion is beyond the time constraints that we have today. But I thought I might just touch on some of the things that I think are kind of important and also some really helpful resources. So in terms of resources, this is what we have available to us at this point in time. So our opiate treatment guidelines, In 2024, clinical guidance for the management of substance use in pregnancy, birth, and the postnatal period. This guidance was updated and published and is a great resource. And then we have the supplemental information around long-acting injectable buprenorphine, which certainly covers pregnancy and the postpartum period and breastfeeding as well. And hopefully, when we have our new guidelines available, a lot of this information will be combined in one place and make it a little easier for us to navigate. So just in terms of some of the key considerations, I think as you'll note here, I'll be talking about opioid dependence treatment, but I may switch into some of the other ways that we describe programs, and I think that varies from publication to publication or service to service. But in principle, opiate dependence treatment is the first-line treatment recommended throughout pregnancy, and we can consider different opiate agonist therapy for use in pregnancy and breastfeeding. And I'll talk to that a little more in the next slide. The principle is avoiding withdrawal. So we want to achieve stability in treatment to avoid withdrawal, which early in pregnancy can result in miscarriage, and later in pregnancy, fetal distress and premature delivery. It's sometimes necessary for us to adjust doses of the pharmacotherapies in pregnancy, particularly later in pregnancy, where there's a change in metabolism of the agents that we use and an increased volume of distribution. So it's important that we're monitoring the patients closely. I think one thing that I did miss was that priority access. So, pregnant women and their partners should be afforded priority access to treatment programs. And there certainly can be occasions where, consideration of, an inpatient admission for rapid stabilization and maybe some antenatal care, could be a useful option as well, particularly if there's a range of other complexities medically or psychosocially for the patient. The medication, once started, is certainly something that we would typically continue postpartum, and we've got here avoiding rapid dose reductions, but I think the key is really considering the stability of the patient and whether anything needs to be done about the dose. We're wanting the patient to remain in treatment, but sometimes we do need to make a dose adjustment, particularly if their dose has been titrated upwards during the pregnancy. So this is a very useful decision-making tool from the Substance Use in Pregnancy Guidance document. So for women who are not currently on an opiate agonist treatment, buprenorphine is typically the first-line treatment option. Now, there will always be exceptions to this guidance, but this is, I guess, sort of standard care. For women already on a pharmacotherapy, typically we would continue the existing formulation and medication, but we need to consider whether treatment is optimal, and if not, what we need to do to modify that treatment to improve stability. If treatment's still not optimal, then there may be an argument for switching from the formulation or the medication. So if we go back to our case of Renee, initially we tried to adjust the dose. That wasn't effective, and so we did have to make a decision to switch the buprenorphine formulation to long-acting injectable buprenorphine, which certainly assisted in terms of stability. Again, this is another useful tool that's in the SUPS guidance, just highlighting some of the considerations in pregnancy. So comparing the different pharmacotherapies, looking at safety and efficacy, but also considering the convenience of the treatment program. So for example, if we look at methadone, whilst it may be an option that it can be easier to start a patient in treatment, it may be hard to make appropriate adjustments to the dose to effectively get to a dose which is therapeutic. Excuse me. Vomiting can also, which is a common problem in pregnancy, can certainly be a problem for patients who are prescribed methadone as well. And that's not an issue for us when we're looking at either of the formulations of buprenorphine. I think another important factor is the safety. So the risk of overdose is certainly higher with methadone, and then other risks in terms of safety of unsupervised doses in the household if there are children or other people in the household. So again, this can be useful in the decision making around a pharmacotherapy. Just shifting to postnatal care. So whilst we're not usually, we're not the lead in postnatal care in decision making, we certainly have a role to play. We have that opportunity through the antenatal period, excuse me, to prepare the mum for what might be expected in the postnatal period, to create an expectation around length of stay, the possibility of the baby needing some monitoring, and also being a part of the conversation with the other care providers. I might skip to the next slide. So discussing and documenting prenatal substance exposure. Sorry, just grab some water. Excuse me, is really important. So both maternal non-medical substance use, but also considering prescribed medications. There are some omissions from this list. So in terms of the non-medical substance use, the use of e-cigarettes certainly needs to be considered as well. And then in terms of prescribed medications, the ones that we've listed, but also considering cannabis, stimulants, as well as nicotine in its various forms. And finally, neonatal opiate withdrawal. So it certainly is something that we need to prepare the mum for. Certainly the length of stay and expectation that, excuse me, the baby will need to be in hospital for a period of time and monitored. When we see withdrawal is varied, and it depends on the pharmacotherapy that the mother is prescribed, and sometimes we don't see significant withdrawal. So the risk of withdrawal, it's hard to predict, but I think it's important to prepare the mum for the fact that it may be an issue. In terms of care, non-pharmacological care is certainly the first line of care, but there are occasions when babies will need to proceed to be stabilised on a pharmacological treatment, with morphine typically being the first line treatment, and then consideration of phenobarb and clonidine in other scenarios.
So in the postpartum, we also must consider the mother. We do have a tendency to focus not unreasonably on the neonatal. There's lots of issues that we need to address, but there are some significant concerns for the mother. And when we typically define the postpartum period as the first 6 weeks after birth, but really it is longer than that. And if we roll that out to 12 months, or even sort of a longer in this context of up to 5 years, we find that drug-induced death is a leading cause of maternal death, and is more likely to happen in the postpartum period than during pregnancy. So it is something that we really need to be mindful of, and ensure that we're able to keep that woman as best we can engaged in care, and meet her treatment needs. This can be difficult. If the woman's had the child assumed into out-of-home care, that is associated with both the withdrawal of some services, but also causes a break in the therapeutic relationship, and that can be a particular risk for her. Other stresses are finance, broken sleep, parenting, as they really are for all parents, but also there is a high higher likelihood of relationships that are marred by violence or interpersonal violence, and that can add stress as well. And it's all of that needs to be considered when caring for the mother. There's specialised postpartum care available for the mother, behavioural interventions for mental health and substance use disorder. It's really important these are tailored to her trauma history. We've discussed that this is much more common in this population of women. These are all the things that those of you who work in AOD treatment do anyway. So I'm preaching to the choir a little bit, but I would like you to think about the birth experience. Now, the case that has just been presented on Renee did show that Renee really felt let down by her birth experience. She felt alone and she felt judged. And this is not uncommon in women who use substances. There is lots of literature on this as well. It needs to sort of be thought about what happened in her birth, how she perceived the treatment. We do know that there is plenty of documentation about women receiving less access to analgesia, epidurals with substance use disorder. That's not always the case, but it can be, and women have described that. And actually, maternity healthcare providers have described not quite knowing the safe way to manage that. It also is possible that there were adverse maternal and neonatal outcomes that are forming part of that distress around the birth experience. It will be important that, as Vicki mentioned, that dose adjustments may be required in the postpartum period, and that there's some thought processes given to how to manage her treatment best. For those who are AOD clinicians, the role in pregnancy care is best summed up by that of advocacy, system navigation, if relevant, preparing for child protection involvement, supporting mental health and safety, and maintaining that engagement in the postpartum period, which is really important for long-term well-being. Now, we've got one more case on contraception. Should we pause for a question, or should I just keep going through until the end?
I can see Sharon's trying to unmute, but I think you can keep going. We don't have questions in the chat at the moment.
Great.
Yes, that's right. Sorry.
So look, we've just talked about postpartum care, so now we're going to move on to contraception, which is a very big part of postpartum care and really does need to be considered. So I'm going to talk to you about Josie. Josie is a 26-year-old woman who was para 3 and had been engaged with the SUP service for the 3rd pregnancy. She had a background of intergenerational substance use and trauma. She had 2 older children. They were in the care of their fathers or their father's family. Josie herself had no family. And she had been managed throughout her pregnancy on sublingual buprenorphine. There was a complex family history, and there was a quite significant risk to her of vascular Ehlers-Danlos syndrome, which she'd never really been fully investigated as she had. So one of the wins I think that SUPs were able to have looking after Josie during pregnancy was to actually arrange for this to be tested, and fortunately was negative, so that could be sort of removed as one of her many challenges. There was a clinician concerned throughout the pregnancy that reproductive coercive control had been contributing to her previous non-contraception use. So contraception was on everybody's mind, but it was a sensitive issue. SUPs remained involved in Josie's care, and at 12 months postpartum, she requested an intrauterine device. And so that just shows the importance of longitudinal management, not pushing too much, but circling back to these issues when safe to do so. Josie remained supported by the SUPS team to make that decision, and then they navigated her to the appointments. The intrauterine device was funded and inserted in a public clinic, so there was no cost to Josie. It's now been in situ for 5 years. The Therapeutic Goods Administration just a couple of years ago have changed the approval for contraception to 8 years, so she still has another 3 years until that needs to be changed. I think we can pause and talk about what happens to women in this space after pregnancy if they have a substance use disorder. So contraception is a core activity of the postpartum appointment, which is conducted at 6 weeks, usually by the general practitioner. Less than 50% of women with a substance use disorder attend that visit. And we know, at least for women who drink alcohol with heavy rates, they have 12 times the odds of a short birth interval, which is defined differently, but in this study was less than 12 months. And we know that short birth intervals are associated with adverse pregnancy and birth outcomes. So that just adds, whilst there's psychosocial benefits for contraception, there are actually potentially other benefits in terms of future pregnancies and their outcomes. We also know in AOD settings, 3/4 of all pregnancies are unplanned. Women tell us that they want autonomy, they want choice, not only around when they conceive, but choice around what methods of contraception they get to use. We know that antenatal contraception education increases the uptake, but that's not always done. There's care navigation seems to be really important, and there are systems barriers to postpartum contraception being provided through the maternity care service. So it is something that often they've discharged from the hospital without having arranged. I've just put this slide up here to show that there are a wide array of different contraception options available to women postpartum. There's sometimes a misunderstanding that women can't use contraception in the immediate postpartum period. Really, there are many things available, with the exception of the combined oral contraception pill. Most things can be started immediately. The combined oral contraception pill needs to be delayed until 6 weeks if the woman is breastfeeding, as it reduces the initiation of breastfeeding and breast milk supply, or if there's an increased risk of venous thromboembolism. Otherwise, you can start it at 3 weeks. I also have down the bottom a little bit about permanent contraception. So it is possible to provide permanent contraception at the time of a cesarean section. It's actually not particularly onerous for us to do this. It takes maybe an extra 3 or 4 minutes and with no real additional surgical risk. So that can be done. And it's something that it might be helpful for women who want it for advocacy in that place. We can also place women on an elective waiting list during pregnancy for a tubal ligation or permanent contraception that could be done at sort of 3 or 6 months postpartum. And I've done that quite frequently. I'm just going to talk to you about a contraception program that Vicki and I have been involved in together. I'll just touch on it briefly for the purposes of you understanding what can be done. But we ran a program that involved education of women, referral to from alcohol and drug treatment services to appropriate gynecological services. It had priority access to clinics. Patients were seen within 2 to 4 weeks. There was no cost to patients. Everything was funded by the program. Patients were transported to appointments, and then there was follow-up with that care navigation as required. The results of the study, I'm really just demonstrating here that there's quite different results. We ran this study in 2 services, one regional and one metropolitan, and vastly different results, which indicates that it's more complicated than just running a service. So we had women who weren't planning to conceive, and roughly half of those in one service took up contraception, and only one patient in the other service. Of those who did take up contraception, most wanted an intrauterine device, and that sort of came out of the quite extensive counselling they got, non-directional counselling on the risks and benefits. That was the device of choice, the method of choice. And I think that's just really important. What we did when we sort of broke down why was this so different amongst the 2 services, and it came away with these sort of core themes that providing a service alone is not adequate, that you really have to develop rapid referral partnerships with local services that are, trauma informed, that are acceptable to patients. It can be helpful if they're co-located, women's health clinics and AOD services, but it's not necessarily required if you've got that care navigation. Particularly in our regional site, the care navigation was done by an AOD nurse who had experience in the substance use and pregnancy service, and I think that provided a really acceptable arrangement for women that they trusted. Having clinical champions around and having people thinking about this regularly is really important, and making sure that we're doing referrals and follow-up support. So bringing everything that we've talked together today, I think is really important. We've talked about care navigation a lot. It is really important in women with reproductive health in this space. Think about self-collected cervical screening, and if that's something you can offer in your area. Don't assume that other services have arranged cervical screening and contraception. They may have, but I think in some instances that gets missed, and it's really something that's quite simple to ask about. Women trust AOD clinicians, and there's a unique opportunity with that trust to provide care and care that might have been missing for some period of time. I think one of the things that I've learned over the years that I didn't really understand in years gone by was that women and babies can actually do really well with opioid treatment program, and there's a bit of a misunderstanding that this is all sort of a lost cause, but there are lots of women parenting very well in the community, like Renee, our second case, who's really thrived with her treatment. When you think about the contraception programs, they can really result in some increased uptake as long as you develop those programs, you redesign them, you think about what your women need, and don't simply just provide a service. The last thing I would touch on is the importance of a no wrong door approach. You saw this particularly in the first couple of cases. The first case with the cervical screening, where we saw the woman wherever we could, and I think it was probably really important in Renee's case as well. The women with these issues don't necessarily walk through the right door, know the pathway to get the care they need, but do really benefit from the help that you can provide. And that's all we've got for today, but we're very happy for questions, and I've got our email addresses there if anyone wants to send us an email, ask questions down the track.